Hi, everybody. This is Dr. Esquivel again. I'm with Max this time.
Hi,
Who
everybody.
he was helped by Zach and Bethina to make this session possible. So this time we're going to be going through the approach to syncope. So these are all learning objectives. We want you to, at the end of this, be able to reproduce a pathophysiologic approach to syncope. Be able to fully characterize the patient's complaint of syncope, and then use your knowledge of illness scripts to diagnose the cause of a patient's syncope during your upcoming session. So, some fundamental principles I want you to uh, use as we go through the approach. So, you will learn that consciousness is regulated at the reticular activating system, which is located in the brain stem of the brain. And in order for an individual to maintain consciousness, there are four things that have to be in place. Number one, there has to be organized electrical activity in the brain. You have to have adequate glucose and oxygen, which are both substrates for metabolism. And then there has to be cerebral perfusion or blood flow to the brain. So that's one set of principles I want you to remember. And then the next are based on some basic cardiovascular physiology. So remember that blood pressure, which is important for perfusion, is a function of systemic vascular resistance, or SVR, and cardiac output. Now, the equation for cardiac output is uh, that cardiac output is equal to stroke volume times the heart rate. I hope this sounds familiar to you. And finally, the stroke volume is equal to the end diastolic volume minus the end systolic volume. So the volume of blood before and after contraction of the heart. So before we go into the approach to syncope, I want to make sure you remember to distinguish syncope, which is defined as temporary loss of consciousness, from other entities which are kind of similar. So when we talk about near syncope or pre-syncope, it is the feeling the patient experiences that he or she may lose consciousness. Sometimes people say that they are lightheaded. It's this feeling of feeling faint or dizzy or being close to passing out. Now, vertigo is completely different from syncope because vertigo is the feeling that you're spinning or that the environment around you is spinning, and then that causes loss of balance. Coma is prolonged loss of consciousness. Okay, so make sure when you're encountering a patient that you clarify whether or not the patient really has a syncopal event. Now, I'm going to show you we're going to walk you through the approach to syncope. As you mentioned, there are four things that are important for maintaining consciousness. And when you have disorganized electrical activity, as you would see in a seizure or subarachnoid hemorrhage, that will cause loss of consciousness. Hypoglycemia is defined as low glucose level, and hypoxia is defined as low oxygen tension. The fourth thing that can cause syncope is poor cerebral perfusion. Now, what causes poor cerebral perfusion? In order for you to perfuse your brain, two things have to be in place. One is that you have to have a patent blood vessel, so an occlusion of the blood vessel will cause syncope, and then the blood pressure must be high enough to cause perfusion. So situations when blood pressure is low is another entity that we're going to be exploring. So as I mentioned, blood pressure equals um, cardiac output times SVR. Oh, before that, I'm sorry. Things that will cause problems with blood vessel occlusion are vertebrobasilar insufficiency, subclavian steal syndrome, and hyperventilation. So, a low blood pressure may arise from a low cardiac output or a low SVR. Situations when the systemic vascular resistance may be low include medications, sepsis, neurogenic or neurocardiogenic syncope, adrenal insufficiency, carotid sinus hypersensitivity, and anaphylaxis. Okay, so what are the causes of a low cardiac output? Low cardiac output states may arise from either slow heart rate or low stroke volume. Slow heart rate or bradycardia may be due to sick sinus syndrome, uh, atrioventricular block, carotid sinus hypersensitivity, or pacemaker failure. Now, what causes low stroke volume? It may arise from high end systolic volume or low end diastolic volume. Diseases associated with a high end systolic volume are aortic stenosis, hypertrophic obstructive cardiomyopathy or HOCM, aortic dissection, and cardiomyopathy. And finally, low end diastolic volume may arise from hypovolemic states, which we've talked about before, or third spacing, pulmonary embolism, medications, cardiac tamponade, dysautonomia, and once again, adrenal insufficiency. And finally, tachycardia also may lead to poor diastolic filling. So think about atrial, supraventricular, or ventricular tachycardias. So I know that this is a little bit of a more complicated schema than we've seen before. The most common cause, or one of the most common causes of syncope, is actually vasovagal syncope, and that's actually a combination of neurogenic syncope and cardiogenic syncope resulting from vasodilation and low heart rate. So um, I'm gonna switch now to Zach, and he's gonna start us with characterization of syncopal events.
Yeah, so when you have a patient who has syncopized, one of the first things that you'll want to ask about is if there are any witnesses there at the event, because you want to make sure that this was a true loss of consciousness, and distinguish it from one of the other descriptors Dr. Esquivel talked about, whether it's pre-syncope or some other situation. You want to ask about events surrounding the episode, if the patient had anything going on situationally before. You want to ask about timing. Was this a sudden event, or was it a gradual onset to the syncopal episode? You want to ask about any changes in position, either before or during the episode. You want to ask if this is the first time, if there's the number, frequency, durations of episodes, if there were anything that made the situation worse, made them feel like they had to faint even more. Then you also want to ask about associated symptoms before and after, things like, did they have any prodromal symptoms? Did they have any confusion afterwards? And then you want to ask about consequences of the syncopal event itself. Did they hit their head on anything when they fell? Did they bite their lip? Were there any other complications, etc.? Now, these are some other parts of the history that can be particularly helpful when interacting with a patient who might have syncopized. You definitely want to ask about any recent changes in medication, any recent changes in diet, oral intake, exercise, activity. You obviously want to ask about any underlying medical conditions such as heart disease, neurologic disease, pulmonary disease, diabetes, and so on. And you also want to take a thorough family history to see if they've had any history of syncope or sudden death in the family.
Yeah, so we're going to first go through situations when electrical activity may be disorganized.
Well, first we'll talk about seizure. You'll learn more about this in brain and behavior, and there are lots of different types, but the general definition is that it's a transient clinical manifestation of abnormal electrical activity in the brain. So we'll talk mainly about the symptoms before and during the seizure. The patients might have things like auras in which they feel different. They might have things like deja vu. During the seizure itself, the things most notable to ask about is if there are any convulsions, any rhythmic shaking of the limbs or the trunk, any tongue biting, any head turning, or any urinary incontinence. Then questions to ask for symptoms for after the seizure. You want to ask if there was any amnesia, any postictal confusion, which is confusion after the seizure that lasts for about 10 minutes. Like I said, tongue biting, any weakness or lethargy or confusion. And this typically you'll see in younger individuals as well as older individuals, people with past history of seizures, multiple seizures. This could also be from CNS infections or different toxins like alcohol or drugs or medications, and is fairly common, being 1 to 2% of all ER visits. Now we're going to talk about subarachnoid hemorrhage, which you'll also learn about a little more in brain behavior, but the thing to know is that it's bleeding within the subarachnoid space in the brain. Usually comes after trauma or a ruptured aneurysm. The classic presentation is someone will say that it's the worst headache of their life. It's a sudden onset severe headache. It may be associated with some nausea and vomiting, maybe some neck stiffness. It could be transient loss of consciousness or some focal neurologic deficits. Typically, there's like hereditary risk factors that could predispose people to subarachnoid hemorrhage, as well as hypertension and smoking being very common as well. And this prevalence typically peaks in the 50s and 60s, so it's usually in your older adults, with 9.1 cases per 100,000 people per year. Next is hypoglycemia. So for this, the symptoms you'd be looking for are things like blurred vision, drowsiness, maybe some impaired concentration, short-term memory loss, numbness. It's usually lethargy. They might also syncopize. Typically, you'd see this in elderly patients, people with long-term diabetes, people taking glucose-lowering medications. So it's really important to ask about specific medications for these patients. Anyone with recent change in their diet or activity. And then this is reported to be about 0.6% in diabetic patients and 4% in patients specifically taking insulin.
Yeah, also don't forget that alcoholics are at risk for hypoglycemia, so that's another population we should think about.
Next, for hypoxemia, this you would be able to determine with O2 saturation in the blood, and really want to think about asking about conditions which would lead to poor ventilation. So neurogenic would be things like ALS, Guillain-Barré syndrome, also any kind of CNS depressing medication like an opioid overdose, and also asking about COPD. For poor oxygenation of the blood, you want to ask about hemoglobinopathies, which can cause anemia and low oxygen retention in the blood. Also about alveolar disease. This can include things like infection or interstitial lung disease. Then for low inspired oxygen, which is the last thing to think about, this would be present for people who are at high altitude who literally can't get enough oxygen into their blood.
Great. So now we're going to talk about 3 situations where there is actually decreased cerebral perfusion.
First, we'll talk about stroke. There are many different kinds of stroke, but the one that would lead you to lose consciousness would be vertebrobasilar insufficiency. So this is a transient decrease in blood flow, specifically in the posterior circulation of the brain. It would present as loss of consciousness. Patients may have hemiparesis or asymmetric quadriplegia. They could have dysphagia, dysarthria, dysphonia, as well as vertigo or nausea. Typically, you see this in patients with atherosclerosis, coronary artery disease, metabolic syndrome with hypertension, hyperlipidemia, diabetes, and AFib is a specific risk factor for stroke in general, with a prevalence of 1 per 100,000 person years.
Yeah, one of the things that I always remind my students is that anterior circulation strokes or diseases involving the carotids would be unlikely to present with syncope. So just remember, this is the posterior circulation we're talking about.
Next, this is a syndrome called subclavian steal syndrome. This results when you have stenosis in the left subclavian artery. And what happens is as you try and increase activity in one of your extremities, that extremity is going to be drawing more blood, and the blood is actually going to flow away from the brain, causing decreased cerebral perfusion. Typically, this is asymptomatic, but if patients syncopize They might also have arm ischemia or symptoms of arm ischemia, like pain or paresthesias in their arms. They might have just increased activity of their arms or move their arms up, which are all things you want to ask about if this is something you suspect. Risk factors include things like vasculopathies, specific Takayasu arteritis or thoracic outlet syndrome. And this is rather rare, but it is important to think about. Next, we'll talk about hyperventilation. So patients might be complaining of dyspnea or chest tightness. It's often associated with things such as emotional stress, panic attacks, anxiety, and fear. So this is more common in adolescent patients, tends to present in women as well. People with hyperventilation syndrome and people with anxiety and panic disorders. And just for prevalence, panic disorder is present in about 4 to 8% of all primary care patients. But typically you'd be able to tell this from the history of hyperventilation.
Yeah, it's interesting because this is not really truly a blood vessel occlusion situation, right? But in when patients hyperventilate, their PCO2 goes down, and that actually is associated with decreased cerebral perfusion. So that's why people actually have syncopal events. Now we're going to talk about situations when there is a low systemic vascular resistance, of which there are several conditions that we need to discuss, and those are situations that lead to low blood pressure.
So first is sepsis, which is a highly variable presentation that most of you will be familiar with, but you can have fever or hypothermia. Patients are usually cold, clammy, have mottled skin. They'll have tachypnea, decreased urine output, and even edema. Risk factors can include any source of infection, but in particular might be indwelling catheters or implanted devices. Anyone who is immunocompromised, whether it's due to asplenia, malignancy, specific infections like HIV, or immunosuppressing drugs like chronic corticosteroids, or high-dose corticosteroids, I should say. And the prevalence is about 2% of all hospitalizations in developed countries. Patients will have sepsis, and it accounts for 6 to 30% of all ICU patients. Next, for SPR-lowering medications, we'll just go through the classes here. So specifically, you want to ask about things like vasodilators, calcium channel blockers, alpha blockers, and antihistamines. And next, we'll talk about our neurocardiogenic illness script, which also includes vasovagal syncope. These two will be mainly situational syncope, which is when someone syncopizes from a specific situation, such as swallowing, defecation, if they have visceral pain, micturition, or even postpharyngeal syncope. Probably the most common situations that we'll have to talk about or ask about are Valsalva maneuvers. So this could be something like playing an instrument, like a brass instrument, laughing, someone's lifting heavy weights, even coughing can cause this. Also, for vasovagal syncope, patients might have prolonged heat exposure. They might have prolonged standing, emotional stress, fear, or noxious stimuli before the syncope happens. So what's really important is that you ask about these prodromal symptoms as well as these situations. So you'll want to ask, did they have sweating, dizziness, or nausea before the syncope happened? And were they in any of these situations that would be risk factors for having vasovagal syncope? And like Dr. Esquivel said, this is the most common cause of syncope, being 45% of all cases. Next is adrenal insufficiency. So the presentation can have a gradual onset of pretty non-specific symptoms such as fatigue, weight loss, most notably skin hyperpigmentation, or it may present in a more acute manner with adrenal crisis, which could be abdominal pain that's so severe that it's like acute abdomen with nausea, vomiting. They could have myalgias, joint pains, syncope, lethargy, and even have such severe hypotension and hypovolemic shock. Typically, so adrenal insufficiency, you'd see a little younger in ages 30 to 50, secondary adrenal insufficiency in 50 to 60 age. This could be caused by things like sepsis, ARDS, severe pneumonia, liver disease, or tertiary adrenal insufficiency caused by corticosteroid use. And that is actually the most common cause of all these. So you'll definitely want to ask about any use of corticosteroids.
Yeah, adrenal insufficiency is kind of complicated because it really depends upon whether you're talking about the glucocorticoid or the mineralocorticoid, right? So, if there is glucocorticoid deficiency, then that will lead to a low SVR state. But low mineralocorticoids, you'll see this again, will be in a different part of the framework because it causes hypovolemia. So that's why you're going to see adrenal insufficiency in two different places.
Now, for carotid sinus hypersensitivity, this is a neurally mediated syncope caused by a normal autonomic response to carotid sinus stimulation. So typically, what will happen is patients will have a loss of consciousness with either looking to the left or right with their neck, or if someone presses on their carotid sinus, they might have dizziness. They could also have prodromal symptoms such as warmth, diaphoresis, or nausea. You want to ask about a history of similar episodes, ask about those triggers, such as turning the neck, maybe they have a tight necktie or tight collar, any head flexion or pressure on the neck that caused this. And typically, risk factors include blood pressure lowering medications, alcohol use, volume depletion. And this accounts for anywhere between 1% and 3% of hospital admissions. So about anaphylaxis, which is something that I'm sure you all are all familiar with. This presentation typically has angioedema and urticaria, which looks like swelling or inflammation. Patients might have itching or flushing. They could have difficulty breathing or swallowing. They could also have a little less common nausea, vomiting, diarrhea, and abdominal cramping. Patients also might have a feeling of impending doom or lightheadedness and faint. The timing can be anywhere from very rapid progression from nothing to severe symptoms, or it may present as a more delayed type syndrome from prolonged medications or things like that. So risk factors, it's most common in children and adolescents, patients with history of atopy or allergic reactions, and you want to ask about exposure to common triggers such as certain foods, shellfish, things like latex, peanuts, any kind of insect bites and stings you want to ask about. And the prevalence is estimated that anywhere from 1% to 15% of patients or people in the United States are at risk for having anaphylaxis.
Yeah, so the next part of our framework are situations when there is an increase in the end systolic volume.
First, we'll talk about aortic stenosis, which presents with a common triad of angina, dyspnea, and syncope with exertion. So these cardiac causes of dyspnea, or syncope, I should say, usually present without any prodromal symptoms and is sudden onset. The patients might also have some dizziness or fatigue or weakness and reduced exercise tolerance outside of the syncopal episode. Risk factors include older age above 60, and then any condition in which patients might have bicuspid aortic valves or congenital aortic stenosis. And this is reported in 12% of all patients over the age of 75, with it being severe in 3% of those patients.
Yeah, aortic stenosis is a fairly common finding in older people, right? So you'd have to think about somebody with a severe to critical aortic stenosis as a cause of syncope.
Next is hypertrophic obstructive cardiomyopathy, otherwise known as HOCM. It's often asymptomatic, but patients may have angina or exertional dyspnea, some lightheadedness or syncope and palpitations, and really can result in heart failure and sudden death. So the main thing that you want to ask about in terms of risk factors is a family history of HOCM or a family history of sudden cardiac death. That would be the main way you'd be able to figure this out because it's caused by mutations in the cardiac sarcomere genes. And this is prevalent in about 0.2% of the general population. Next is aortic dissection. So this presentation is like a sudden onset of severe pain in the chest, back, or even abdomen, although that's less common. And the pain is usually described as a ripping or tearing, and it's typically sharp or stabbing. And patients, up to 15% of patients can have syncope from an aortic dissection. The associated symptoms are mostly related to end organ ischemia. So you might see numb lower extremities. You could have non-specific abdominal pain from mesenteric ischemia, gastrointestinal bleeding. You could have dyspnea or pulmonary edema from compression. Risk factors include genetic disorders as well as vasculitides and hypertension. And prevalence is typically men in their early 60s and women in their late 60s. Those are the peaks for aortic dissection. And lastly is cardiomyopathy, which we've talked about before. Typically the presentation is heart failure, which we've done, but severe enough to cause syncope. Risk factors we've discussed, but you want to ask about medications, alcohol, certain conditions like hemochromatosis or infections that cause myocarditis. It could be endocrinopathies that you might want to ask about and different genetic disorders. The prevalence is just that dilated cardiomyopathy is the most common cause of heart failure worldwide, which is often caused by things like alcohol.
Yeah, when we think about cardiomyopathy or congestive heart failure, you'd actually have to be in a cardiogenic shock state for that to present as syncope. So it's a rather unusual presentation of cardiomyopathy. However, patients with cardiomyopathy are at risk for ventricular arrhythmias, so that's something that we'll talk about in a little bit. So the next part of the framework are situations when there may be a low end diastolic volume, and a lot of these are associated with hypovolemic states or situations of tachycardia.
So first is dysautonomia, which you might know as orthostatics or orthostasis. This happens when we have a decrease of return blood to the heart upon standing due to insufficient compensatory contraction of the veins. So there are different causes. Specifically, there's some familial dysautonomia, some autonomic system neuropathies that might cause this. So you might want to ask about family history, ask about dehydration, and this is very common in terms of causes of syncope. So you'll want to ask about patients. This is when you want to ask about patients in terms of their change of position, like standing up too quickly or going from lying to sitting. The multiple systems atrophy and Shy-Drager syndromes are rare genetic diseases that are a little less common. And same with familial dysautonomia, but it is present in 1 in 3,700 patients among the Ashkenazi Jewish population. For EDV lowering medications, these include our vasodilators, our diuretics, and their presentation is similar to orthostasis, where the patients might have changes in their position before syncopizing. But you want to ask specifically if they're on any medications that might be making it worse. And lastly, we have tachycardia. So these include our arrhythmias, which are paroxysmal ventricular tachycardia and paroxysmal supraventricular tachycardia. Patients will typically complain of having palpitations. They might have lightheadedness or syncope. And like I said, with the cardiac syncopes, it's typically sudden onset with no prodromal symptoms. So you'll have what's called a drop attack. You might have symptoms relating to the underlying cause of these arrhythmias, such as things, so risk factors include structural heart disease, histories of myocardial infarction, cardiomyopathy, or arrhythmia syndromes.
And the last part of our framework are conditions that lead to slow heart rates or bradycardia.
So here are two main syndromes that we'll talk about is sick sinus syndrome and atrioventricular block. So for sick sinus syndrome, it can be very variable, where you can have actually slow heart rates and fast heart rates. If it's severe and prolonged sick sinus syndrome, you might have that sudden cardiac syncope. If it's less severe, patients might be complaining of weakness or dyspnea, angina. They might have near syncope or TIAs. And this is also associated with SVTs, mainly AFib. And you typically see this in your elderly patients with underlying cardiac disease and medications that may depress the sinus node. Then for AV block, it's very similar, where patients might be asymptomatic. They could have syncope or near syncope, palpitations, angina, dyspnea, fatigue, TIAs is very overlapping. And the same thing with the epidemiology is that the incidence increases with age. Patients after an MI might present with AV block. And there are some specific infections to remember that can cause this on their own.
Yeah, so just to kind of review this, I know that's a lot of information, but I think as you go through your history, what I usually do when I'm approaching a patient with a syncopal event is I usually try to figure out, what the events were that led up to the syncopal event. I try to figure out, is this somebody who is at risk for hypoglycemia or hypoxia? Um, was the event associated with seizure-like activity? Um, are there any neurologic symptoms that suggest it might be a stroke? I then pursue questions related to the cardiovascular system, right? I think you'll sense that a lot of the diseases we mentioned actually are cardiovascular in nature. So asking questions about chest pain, shortness of breath, palpitations, all of those are actually going to lead you down the path to low blood pressure states. Um, Figuring out whether there have been any changes in medications is really, really important. Don't forget about pulmonary embolism, because there was one study that showed that patients who come to the ER with unexplained syncope had a PE in about 17% of cases. So it may look like a complicated framework, but if you really think about the four primary mechanisms for causing syncope and use your understanding of cardiovascular physiology, I think you should be able to figure out why patients develop a syncopal event, or at least develop a hypothesis as to the most likely cause. So the following slides are provided to you just as a way to remind you about the other things we had mentioned before in previous sessions. So once again, the symptoms of intravascular volume depletion, of vascular lung diseases like pulmonary embolism, pericardial diseases that lead to tamponade, and that's about it. So once again, thank you very much for your attention, and thank you very much, Max.
Thank you, guys.